talk about adult people with HIV, there are important general principles that apply to the use of vaccines. In terms of efficacy, evidence predominantly comes from studies of immunogenicity, whereas there are limited data of clinical efficacy in this population. We know that several vaccines show reduced immunogenicity in people with HIV, and this may translate into, for example, lower antibody response and into responses, antibody responses which are reduced in duration. We can use several strategies to boost immunity in this population, and this could be, for example, to prefer certain vaccine formulations, to modify the vaccine dosing strategy by using higher doses or more frequent doses. Certainly, giving the vaccine in early HIV infection before a significant immunocompromise is an important way of increasing immunogenicity of the vaccines, and also immunogenicity is boosted by giving the vaccination after immunoreconstitution on ART, on virologically suppressive ART. However, when we come to the use of vaccines that are non-live, so this could be RNA, DNA, or protein, or inactivated vaccines, in this case, although immunogenicity may be reduced, and although there may be circumstances where it may be appropriate to defer vaccination until after immunoreconstitution, in the majority of cases, the recommendation is to give the vaccine and then consider perhaps revaccinating after there is immunoreconstitution on ART. In the case of live vaccines, then these are not recommended if the CD4 count is below 200. When the CD4 count is above 200, preferably on ART, then a risk-benefit evaluation is done. And the risk-benefit evaluation, for example, will be in favor of vaccinating non-immune people with HIV against measles and varicella, but it will not be in favor of using BCG in this population. Now, when we come to the general recommendations, we see that recommendations for non-live vaccines that apply to people without HIV also apply to people with HIV, but there are some specific indications. So, for example, in the case of influenza, for adults with HIV, we continue to recommend the use of the inactivated vaccine, although there is now good evidence of safety of the live vaccine in people below the age of 18. But the safety data for older populations older than 18, are simply not there. If available, the quadrivalent vaccine should be preferred, but vaccination should not be delayed while waiting for it, and the trivalent vaccine may be used instead. For pneumococcus, many prefer a prime boost approach, whereby the conjugated vaccine is given first, and then this is followed by the polysaccharide vaccine after at least 8 weeks. Now, the conjugated vaccine can be given regardless of CD4 count, whereas the polysaccharide vaccine may be given at the lower CD4 counts, but there is an argument here for delaying the vaccine until after immunoreconstitution in order to improve its efficacy. In general terms, many do not recommend further doses after the 1 dose of the conjugated vaccine and the 1 dose of the polysaccharide vaccine. But in some guidelines, we will see that the 2nd dose of the polysaccharide vaccine is recommended, but there should be at least a 5-year interval between the 1st dose and the 2nd dose. For HPV, the nanovalent vaccine is recommended if available. 3 doses continue to be recommended for people with HIV. And we see also that different guidelines, different countries apply different eligibility criteria, for example, based on age or risk group. And there could be, for example, guidance to offer the vaccine to all MSMs up to the age of 45. For meningococcus, we also see that often prioritization is for those particularly at risk, so for example, MSM. In the case of zoster, the vaccine recommended is the recombinant one, based on evidence of greater efficacy in people with HIV compared to the attenuated vaccine. But if the recombinant vaccine is not available, then the attenuated one can be given, the live attenuated one can be given, but the CD4 count must be above 200, and also there must be evidence of vis-a-vis IgG seropositivity before giving the vaccine. The age cutoff is 50 for the use of the zoster vaccine in people with HIV. For those who are non-immune, hepatitis A is recommended. 2 doses are given, although there may be a consideration of giving 3 doses to those with a CD4 count below 350 if at risk. For hepatitis B, here is a situation where standard vaccines have reduced immunogenicity in people with HIV, and strategies to improve the response is to increase the dose, so use 40 micrograms, so the double dose, sometimes this is described as a double dose. To give 4 doses is also recommended, and also to measure the anti-HBs response is recommended so that one could decide upon boosting and or on revaccination strategies. Obviously, there are newer hepatitis B vaccines with specific adjuvants, and in this case, we do not recommend increasing the dose because of lack of data. We discussed already vaccination against measles and also vaccination against varicella. The measles vaccine is given in the context of the measles, mumps, and rubella vaccine. It's important to say that the vaccines, MMR and varicella vaccine, these are both live vaccines. They should not be given at the same time because of lack of safety data. For yellow fever, CD4 count above 200, and also a risk-benefit assessment is needed because this vaccine has problems with side effects, particularly in the older age groups. We continue to not favor the use of the attenuated typhoid vaccine, and we already discussed influenza and BCG. So let's move now on to vaccines against C19 in people with HIV. In recent times, in recent months, we have seen data indicating that there is an increased risk of severe C19 in a subset of people with HIV, and this may be associated with poor immunofunction, persistent inflammation, perhaps with lack of virological suppression. And certainly in people with HIV, as in people without HIV, increasing age and comorbidities play an important role in increasing the risk of severe C19. These are the data sets that have compared people with HIV with people without HIV in the same study. And they've come to the conclusion that people with HIV have an increased risk of severe outcomes. The most commonly measured outcome is C19 death. And the increased risk is between 2 and 3-fold relative to people without HIV. So this is an important observation that clearly underlines the importance of giving the C19 vaccine to people with HIV. Also interesting to see data that have been recently presented from Public Health England, looking at 99 people with HIV who died in England during the first wave of the pandemic. Their median age was 60 years. Interestingly, 68% were on non-white ethnicity. This compares with 35% of people with HIV in the UK being of non-white ethnicity overall. We can see that overall this population who died with C19 had a long-standing HIV infection, were engaged with care, usually were unarmed with virological suppression, and a 58%, proportion of 58% had a record of a CD4 count below 350 in the previous year. We can see that 90% had at least one comorbidity, particularly cardiovascular disease, obesity, diabetes, renal disease. So, as we said, the data are compelling and make us recommend strongly that people with HIV should be vaccinated against the C19. They should be prioritized for vaccination, and they should complete the vaccine series, so receive promptly the 2 doses of of vaccine dosing schedules that comprise 2 doses. And this recommendation to complete the vaccine series also extend to those that have previous evidence of infection. Which vaccine, in terms of safety, based on the overall assessment, mRNA, adenovirus vectored, protein or subunit, and inactivated vaccines can be given to people with HIV regardless of CD4 count, viral load. There are no specific safety concerns that apply to people with HIV, and the contraindications and the general warnings will be the same as in people without HIV. So this obviously is an area where the data are rather limited, and although we can be reassuring about what we know about the safety, we certainly don't have sufficient data to be absolutely firm about these vaccines in people with HIV. And particularly when we think about the efficacy, we cannot exclude that there will be differences in efficacy between these vaccines, but there are no data at present to recommend one vaccine over the other. This is a clear research need, how the different vaccines work in terms of efficacy, as well as, of course, safety in people with HIV. So we can see that the major available vaccines have commonly, although not always, included people with HIV. However, it's important to highlight that the eligibility was having well-controlled HIV infection, and people with significant immunocompromise were excluded from these studies. So what is the evidence? In the case of the BioNTech, Pfizer, and these 3 trials did include the people with HIV, but there were less than 200 people in each study. And an FDA review that was performed in February 2021 concluded that the data were insufficient to perform separate safety or efficacy analysis for people with HIV. However, when we looked at people with HIV in the context of people with underlying medical conditions grouped all together, we saw no marked decline in efficacy of these vaccines and no safety flags. We have recently seen the publication of the Novavax phase 2b study in South Africa, looking specifically at the primary efficacy analysis, which was performed in 2,684 participants who were SARS-CoV-2 seronegative at study entry. Among these, we had that were people with HIV, and the vaccine efficacy was 60%. When the analysis excluded this subset with HIV, and 49% when including this population. And of the cases of C19 that occurred, and this could be any case from mild to moderate, for example, or obviously severe, all the cases, well, the vast majority of the cases of C19 that occurred, approximately 93%, were due to the B1351 variant. This data suggests reduced efficacy of the Novavax vaccine in people with HIV, but the numbers are small and the confidence intervals are very wide and in fact overlapping. So no firm conclusions can be made. What about the J&J vaccine? They included in their phase 3 study just over 1,200 people with HIV randomized to vaccine or placebo. Here, the primary endpoint was moderate or severe or critical C19. And there was a co-primary endpoint of measuring this outcome if the onset was at least 14 days post-vaccination or at least 28 days post-vaccination. At the 14 days analysis, there were 5 cases among people who received the vaccine and 5 cases among those who received placebo. So there's no vaccine efficacy to be measured here among vaccinated people and people who received the placebo respectively, which will give us a vaccine efficacy of 48% among people with HIV. But the confidence interval is too large to even write it down. The overall vaccine efficacy in a population without comorbidities in this study was 69%. So what about immunological studies after C19 vaccination? We have this study, which is in preprint, looking at people with HIV, comparing 54 people with HIV to 50 people without HIV after vaccination with the AstraZeneca vaccine, 2 doses, 4 to 6 weeks apart. And the outcomes were measured through day 26 overall in this population. Now, important to appreciate that there were no significant differences either in safety or immunogenicity between these 2 groups. And looking at immunogenicity, anti-spike IgG, neutralizing titers, and also T-cell responses were similar. We can see here in the graph that overall the T-cell responses measured by interferon gamma ELISpot assay were essentially identical. We can say they were very similar between people without HIV. There was also no correlation between CD4 counts and anti-spike IgG titers in this study. But important to appreciate, these were younger people with HIV, aged 18 to 55, median 43 years. They were all males, 82% were white. They were all virologically suppressed on ART, and they had a CD4 count which was above 350. And the median, as you can see, was 694. We can say this is a very well-controlled population, and also is a population in the UK that is less likely than other populations to be diagnosed late. Similar data also coming from a study looking at people that received a single dose here in this analysis of the biotech mRNA vaccine, and the analysis here looked specifically at a comparison of people that either had HIV or didn't have HIV, and also either had or didn't have a previous SARS-CoV-2 infection. Basically, very good responses in terms of antibody responses and also interferon gamma T-cell responses in the 2 groups, with a good boosting seen after a single dose in those that had a previous infection with SARS-CoV-2, regardless of HIV status. However, again, here the HIV population, these are small numbers, the HIV population was all virologically suppressed. We have also seen other data. These are the data not strictly pertinent to vaccination, but rather pertinent SARS-CoV-2 infection in people with HIV. This study compared 47 people with HIV with 35 people without HIV, and immunoresponses were measured 5 to 7 months after the infection. Again, for the population with HIV, these were virologically suppressed with a median CD4 count of 560. There were some patients, however, that lower CD4-CD8 ratios. When we compare the two populations overall, there is no dramatic difference in neutralizing antibody titers or in T-cell responses. However, we can see that T-cell responses were reduced in the population with HIV who had a low CD4-CD8 ratio and also had a lower, smaller pool of naive T-cells. More dramatic, this is vaccination with 2 doses of the biotech mRNA vaccine in someone with uncontrolled HIV infection. Patient was diagnosed with a CD4 count of 20 following the vaccination, very high viral load, started antiretroviral therapy, and a sample was taken at the start of antiretroviral therapy and for day 44 when the viral load had been suppressed and the CD4 count had gone up from 20 to 70. And these 2 blood samples were tested for anti-spike IgG levels, for neutralizing antibodies, and also for interferon gamma ELISpot T-cell responses. And basically there were no responses at all. No antibody responses, no T-cell responses. Some of the data about the impact of immunosuppression come from a different population. These are solid organ transplant recipients that received 2 doses of an mRNA vaccine. And what this data show is that only 15% had detectable anti-spike IgG after the single dose. But encouraging, the proportion of those with a response went up to 54% after the second dose. So it's important to complete the vaccine series. It's likely to increase immunogenicity of these vaccines. So what can we say? The data are very limited. There are some emerging but still incomplete pieces of evidence that indicate what the risk factors, HIV-related risk factors, could be both a severe C19 and also a reduced response potentially to a vaccination. Nadir CD4, current CD4, CD4-CD8 ratio, inflammation, viremia. Of course, we don't know how these factors influence the different vaccine types. So which approach should we follow if a patient is identified as being at risk of a reduced response to vaccination? We should not defer C19 vaccination while waiting for immunoreconstitution. We should certainly recommend that the vaccine series is completed to improve the response. This is an area where obviously one will potentially consider revaccination again, either before or even after, immunoreconstitution, so more vaccine doses perhaps, or certainly try to revaccinate, boost after immunoreconstitution where feasible. But obviously this will need to be based on the evolving recommendations about boosting requirements for at-risk populations. In the meantime, I think it's important to counsel patients that may be at significant risk of reduced vaccine efficacy, and to counsel them appropriately, also sharing some of the uncertainties that we still have. There are important research needs. What is the role, for example, of post-vaccination antibody and perhaps interferon gamma testing? What is the potential effect of different vaccines, but also different vaccine schedules? And what are the exact vaccine requirements in this population after an infection is diagnosed? For example, is it all or is it just a subset? And I think this talk will not be complete if we didn't tackle also the issue of vaccine uptake. I think we all have the experience of patients that, having been offered the C19 vaccine, have declined for various different reasons, declined or said that they will postpone the vaccination. And this is a general issue. We know that across a range of recommended vaccines, uptake remains incomplete among people with HIV, and there is certainly here the need to boost vaccine uptake. And this must be done with different strategies, but there is one which different studies have highlighted as being really very important, which is certainly access, but also is the direct offer coming from a healthcare provider. This is a very important element that will certainly help boost vaccine uptake. For example, there was a recent study done in the US among 101 Black American adults with HIV, and more than 50% of them had various reasons, or at least one reason, for not trusting the C19 vaccine, didn't really believe in the vaccine. However, in the same survey, it was also clear that social service and health providers were the most trusted source of information. So importance of offer to boost uptake. I think it's also important to share knowledge and information among healthcare providers to remove barriers, to remove some misconceptions about safety and efficacy of vaccination in people with HIV. And of course, increasing awareness and knowledge among patients themselves is likely and is known to boost vaccine uptake. We also need to stay sensitive about disclosure worries. For instance, a few days ago, I remember that a patient of mine was being offered the vaccination against the C19, and his question to me was, I have a young age, those in my age group have not yet been vaccinated. I am being offered the vaccine because I'm prioritized due to my HIV status, but I haven't disclosed this to my employer. What do I tell them? Perhaps ask me about vaccination. What do I tell them? Why have I been vaccinated? So having something ready, for the patients to use when they are not prepared to disclose the reason why they had the vaccine, I think it's important. We also need to stay sensitive about the psychosocial and economic determinants of vaccine uptake. Several studies have shown there are groups at risk, those who are foreign-born, younger people, younger MSM, and of course those with socioeconomic challenges. And I think identifying this group at particular risk is important. And it's important also to appreciate that they are often the same people who struggle with some of the HIV-related health measures, adherence, control of viremia, and good CD4 count recovery. So these are a very vulnerable subset that we need to identify and support. So let's come together as HIV treating community to make sure that we help our patients to have a good uptake of the recommended vaccines. Thank you very much.
So thank you. Okay, I think this is my turn. I hope that you can hear me. Thanks to the organizers for their invitation, and thanks to Jean-Pierre for his kind words. So I'm at the head of the Virus and Immunity Unit here at Institut Pasteur in France. And in our lab, we are studying how human pathogenic viruses, HIV, but also SARS-CoV-2, replicate and interact with the host immune system. Today, we'd like to discuss post-infection versus post-vaccinal SARS-CoV-2 humoral ET. And my talk will be divided into 3 parts. I will start by a brief introduction on SARS-CoV-2 entry and fusion. I will discuss the variants of concern and how they may fuse differently depending on each virus. The main part of my talk will be on the sensitivity of these variants to different kinds of antibodies, and I will finish by a few words of conclusion. So let's start by the beginning, viral entry, SARS-CoV-2 entry, and you have here a representation. This is a cryo-EM representation or image of the viral particles. The pointer here. So on the middle panel, you can see the 3D reconstruction of the coronavirus particle with the trimeric spike, which is present at the surface of the viral particle, and which may adopt different conformations. I won't go into details, but I just would like to mention that the receptor on the right panel is the molecule ACE2, which is interacting directly with the RBD, the receptor binding domain of this spike protein. So how does the virus enter? So it binds to this receptor, ACE2. There are other co-receptors that are currently being studied. And then upon binding, there are some cellular proteases, mainly the furin, but also TMPRSS2, which is a cellular protease present at the cell surface, will cleave the spike precursor, and this will allow some conformational reorganization and exposure of the fusion peptide, which will lead to the fusion between viral and cellular membranes. This fusion can occur also after internalization of the viral particles, after endosomal internalization, and some endosomal proteases like catepsins can also cleave the precursor, and then the virus will enter after endocytosis. And once the cell is infected, some spike proteins can be exposed at the plasma membrane, and this may lead to the formation of syncytia. This is a well-known process for different kinds of enveloped viruses, including HIV. And we have a long-standing interest in studying those syncytia. How are they formed? And that's what we have been currently doing with SARS-CoV-2. What is their role? Are they a dead end for viral replication, or do they facilitate viral escape? Do they trigger inflammation? So those are the questions that we are currently addressing.
Can you share the screen? Because we see you, but we don't see the slides. They're very small.
I don't know how to do that. I think.
Elodie, can you share the screen, the slide?
I think you need to épingler the screen. Is it okay for?
I can see it.
You see
it's okay.
You see the full screen. Okay.
Yeah.
So maybe Jean-Pierre, you need to click on the window. Is it okay for you now?
I have pin. Okay, I have to press pin. Okay, thank you.
Okay, so yeah, I was saying that those syncytia are maybe some kind of pathogenic features of severe COVID-19 infection, and I wanted to quote two articles by Jaka in London, including one recently published in Nature, in which they described the presence in the lungs, so through autopsies of large syncytia, which are formed between infected cells and neighboring cells, and they were present in most of these patients. We don't know, again, exactly their role, and that's precisely what we are currently studying. So I would like now to show some of the cellular tools that we are using, both to study SARS-CoV-2 fusion, but also to study the effect of neutralizing antibodies. And we designed a cell line, which is termed U2OS, this is adherent cell line, and we selected this cell line because it is very flat, so it is easy to do automated imaging, and I will show you some of the interest of those cells. So those cells, they do not express the receptor ACE2 on the left panel, so we design cells expressing ACE2. And then you can see that upon infection, the parental U2S cell on the right, they do not get infected, but if we infect them, if we infect the U2S ACE2 cells, then they are highly sensitive to infect. We also introduced in those cells the GFP split system. So in this system, you have two different kinds of cells. One of the GFP protein, whereas the other part will express the other half. And when the cells are fused together, the cells will become GFP positive. And you can see here, at 24 hours post-infection, the formation of large syncytia, which are spike positive. And with this system, we can follow in real time by video microscopy the formation of syncytia in cell culture. And this is an example of infected cell culture on the right panel, whereas on the left you see non-infected cells. And as soon as 5 to 6 hours post-infection, the syncytia are being formed, and the cells will fuse together, generating those large multinucleated cells, which end up dying in this culture. So we termed those cells S-fuse cells, and we have now the S-fuse assay, which is very simple. We can prepare the cells, use 96 well plates or 384 well plates, incubate the cells with a virus in the presence of sera or any kinds of drugs to be tested. And after overnight incubation on the right, you can see, so this is a 96 well plate. We have algorithms to measure the GFP positive cells, and we can calculate viral titers. And we are using this assay to first to follow the neutralizing activity of sera, antibodies. We are testing some antiviral molecules. We are also able to titrate infectious virus in nasal or nasopharyngeal swabs and any kinds of human samples, but I won't have time here to discuss these experiments. And we are also using that to study the role of the innate immune response that I won't discuss today. So this is an example of a 96 well plate, and you can see here we have tested 4 different sera. The sera number, and we make serial dilution, and you can see here that the serum number 2 is active up to 2,700 dilution, and so we can easily calculate IC50s with these cells and using infectious virus. So now a few words about the viral variants and how they may escape from the immune response. So you are all aware of the appearance of these variants, which emerged at the end of 2020, and they are represented here. So how did they emerge? Probably they escaped the natural immunity jail, which is represented here. And it's interesting to see that there are a few mutations within the RBD, but also within other regions of the spike, which were selected in different regions or countries, meaning that there was a kind of convergent evolution in different regions, and the combination of the different single mutations or deletions make the signature of these different variants. And are they sensitive to the immunity induced by the different kinds of vaccines which are currently available? So you know that there are different variants of concern, and the one of the most important is the B117, which was originally identified in UK, and you have here it's the panel of mutations, and on the lower panel, you can see where those mutations are situated on the spike. And you have also the so-called South African and Brazilian variant. They display, again, different kinds of single mutations, but they have a common mutation that you barely see here, which is N501Y, which actually facilitates or enhances the affinity to the ACE2 receptor, whereas other mutations, such as the E484K here, allows escape from neutralizing antibodies. And this mutation is present in the South African and Brazilian lineages. And you know that those variants spread very rapidly. This is an example of the B117 spreading in England, which was first identified in October 20 in the Kent region. So that's why it was initially termed the Kent variant. And then it progressively 98% of the sequenced or identified variants. And in France, now it represents about 80% of the circulating viral strains. More recently, you have the so-called Indian variant. Actually, this is a family of 4 different variants, B1.617, which are represented here. And so the mutations are somewhat different from those described in the 3 first variants that I just presented. There is an important mutation, which is L452R, which is also present in the Californian variant of concern, and which allows antibody escape, probably. And in England, the B1.617.2 is currently spreading and is now considered as a variant of concern in England. And the whole lineage is under a constant evolution and is also considered by the WHO as variants of concern. So now I would like to share with you some of the few experiments that we did. And the first question that we asked is, what is the sensitivity of the so-called UK and South African variants to neutralization by sera from convalescent individuals? So we collaborated with different virologists in different French hospitals at Orléans and Strasbourg. And we tested at different time points, 6 months after infection, even 9 months after infection with the Strasbourg cohort, with the Samira, 13 months post-infection. And with Samira, they studied and we helped them doing the neutralization assays, more than 1,000 healthcare workers, whereas with Thierry Prazuc and Laurent Auclou at Orléans, we studied different kinds of individuals, including a few of HIV-infected individuals. And this is a typical experiment here. On the upper panel, you can see different neutralization curves with single individuals. So you can see that's the same individual on the left and middle panel at different time points, 3 months and 6 months post infection, and you can see that you need at least 10-fold more antibody or to neutralize the B1.351 variant compared to the B1.117 variant. And that's also the case here. On the lower panel, you can see that the so-called South African variant is more resistant to antibody neutralization than the other variants. And the UK variant behaves similarly as the ancestral strain. More recently, and this is a study being performed by Samira Fafi-Kremer, so they studied up to 13 months the decay of antibodies, and actually the slope of antibodies decline is quite low, and they were able to calculate that the half-life of anti-spike antibodies is probably 2 years. So meaning that the infection might provide long-term protection. And it is interesting to see on the on the right upper panel that vaccination strongly enhanced the levels of those antibodies. This has been shown by different other teams. And there is about a 1 log or 2 logs increase in the antibody titers, and this is also seen on the lower right panel. There we were able to see a 2 log increase in the neutralization titers. And even with the South African variant, which was almost not neutralized, strongly enhanced the neutralization activity of these variants. So regarding the vaccines, I will be quite fast. Here, that's results obtained with the Pfizer vaccine. We are following on a weekly basis a cohort of individuals, and the titers after the second dose are quite stable. Now we are about 4 to 6 months post-vaccination, and it's not really visible here, but the titers, the neutralizing titers on the lower panels are quite stable, but start to decline with the ancestral strain on the left, with the UK variant, and they are particularly low, but still detectable with the South African strain. So those are results obtained using only the sera of these vaccines. What happens in the real world, this was already discussed by Anna Maria. It depends on the vaccines. The Pfizer and Moderna, the vaccines are highly efficient against both the ancestral strains and B117. And the Pfizer is also very efficient against the South African variant. With Novavax, the efficiency seems to decrease against the B1351 vaccine. And that's also the case with the Johnson & Johnson vaccine, whereas the Oxford AstraZeneca, which seems to be a little less efficient against ancestral strains and B117, is poorly efficient in vaccinated individuals to prevent infection. So, due to time, I will conclude now and say that we have developed a panel of assays to measure antibody levels and function. So I've shown you the SFuse assay, which is rapid, semi-automated, and it's easy to adapt to novel variants. And we are currently finishing a study using the B16172 strain, so the so-called Indian strain, and studying its sensitivity to monoclonal antibodies, polyclonal antibodies, and from vaccinees and convalescent individuals. What else? So, and I didn't have time to share with you our ongoing work on the fusion, replicative fitness, sensitivity to innate immune responses of the different variants, because one must not forget that the different variants are not only facing the humoral immune response, but also the cellular immune response, as well as the immediate innate means of defense of the organism. And I will stop here. Just to thank all my colleagues from my lab and collaborators. I'm very lucky to have this very dynamic and talented team, and we are interacting with a lot of other teams here at Institut Pasteur, but also with virologists and clinicians from different French hospitals. And I will stop here. This is our team, and thanks also to our funding agencies. Thank you.
What we see is that in the absence of variants and in HIV positive people who are very well suppressed, the message is clear that it's important to be vaccinated and that that the vaccines are protective. And then things get a little bit more complicated with people who are less suppressed. I thought the question, Anna Maria, even though it was an N of one, very becomes more complicated when people are not so well suppressed. So there are a few questions. One is for you, Professor Jureidi. Are you, and it sort of relates to this, the question is, are you aware if vaccine could be useful early in infection in order to avoid severe forms? So is it important to get vaccinated? And then how frequently would you vaccinate people who are optimally suppressed versus not so suppressed in their HIV?
So the first question is very interesting. We know from other disease areas, other infectious conditions that you can sometimes use vaccination early on after exposure to prevent perhaps not the infection itself, but rather prevent complications of the infection. But I'm not aware of good solid evidence for people with HIV in this space. In fact, there is very limited evidence anyway in general about vaccination for C19 in this population. Very interesting research question. I don't know if Oliver has got any idea about whether there is a beneficial impact from outside populations with HIV. I'm not aware of data, but there will be data about nested within the clinical trials, but I've not seen those analyses.
And then another question is, does cytokine storm get impacted by the vaccine, by the COVID vaccine in HIV-infected patients? Policy in such situations, not known.
Is this the cytokine release storm that may be caused by C19? Again, I mean, we don't have data. I mean, we wouldn't have people that are very ill willingly vaccinated against COVID-19, because one of the contraindications of giving the vaccination is indeed having an acute illness. And people, in fact, most guidelines would recommend that if there is an active diagnosis of C19, vaccination is postponed until resolution or at least 4 weeks after the initial positive test. So this is the guidance. Therefore, unless we do studies specifically on how vaccines, in someone already, with the infection and the disease, I'm interested in data that are emerging about vaccination in people that have prolonged symptoms of C19. This is not people with HIV necessarily, right? This is just in the general population. We've seen some data now suggesting that vaccinating people that have this long tail of symptoms, what we call the long COVID, seems to have a beneficial effect, which makes you think that there is some potential modulation of cytokines. Maybe I don't want to, go too far away with my thinking about this, but there is potential for that. But within the population with HIV, there are no data. I think the other question is to whether what to do with repeat doses of vaccination. Of course, this is an important point. I know that in France, for example, there's recently been a recommendation to add the third dose of vaccination in people who are immunocompromised, and I can see the rationale for that. Of course, the evidence for people with HIV is simply not there. And what will be the benefit of further doses is something that, in fact, I've suggested that probably there is a scope, for instance, post-immune reconstitution for repeating the vaccine. I think we really need to build up some evidence base, at least to start developing a consensus around the best way forward for this population. But
But
certainly the point about, giving the right advice to people, if there is profound immunocompromise, then there is a risk of, lack of vaccine efficacy, and people should be counseled about that, I think.
Okay.
And the role of perhaps monoclonal antibodies in that population is something also to consider. Sorry, just long answer.
Okay, thank you. And a question perhaps to both of you is your thoughts are about plasma and serum therapy, whether you would recommend it or not, but for people who are infected, given the recent Lancet article suggesting that there is no appreciable advantage.
Maybe I can say a few words. So I'm not a clinician, so I don't recommend anything. But just, at least the monoclonal antibodies seem to be very efficient when they are given at an early time to people at risk of developing a. It is. I can say a few words regarding the variants, because we and other teams as well did some studies with at least four. We used 4 different therapeutic antibodies, and we studied their efficacy against the different variants, including the Indian variant. This is ongoing work, and it depends on the antibody. And for instance, the Lilly antibodies. One of them is much less active against the variant, whereas this is not the case for one of the Regeneron antibody. I don't. So of course, so that's a very important to know. And before giving this kind of treatment, it's important to define or to sequence the virus and to. Because otherwise this could be also a mean to select novel escape mutations if you give optimal antibodies.
Yeah. So Olivia, there's also a question if different variants of concern are transmitted more rapidly, in your opinion.
This seems to be the case. This has been well documented for the B117 variant. The transmissibility rate is about 60 to 90% higher than with the ancestral strain, and this explains why the virus has spread so efficiently. This is probably the case for the other variants, even if this is less documented. And the B117 UK variant was initially thought to be more aggressive, more lethal. This was published in Nature, and then there was at least 2 other studies showing that this is not probably the case. So the higher transmissibility is clear, and this is probably the case for the so-called Indian variant, at least for B1672. But in India, well, the epidemiological data remain rare at this stage.
Okay, and then there is a question asking whether you recommend individuals who are dual HIV and solid organ transplant on both antiviral and anti-rejection medications, whether they should be boosted and at what frequency. Okay.
Obviously, we have seen the data. I've shown, the data from the solid organ transplant study analysis done in the US. There is a boosting effect of a second dose. What about the effect of the third dose? I think we'll soon get data from France, since this has now become a policy there. We will certainly be looking very carefully at those data to update our recommendations. At present, I don't have a clear answer about the frequency of boosting. And this has to be taken into context also into the context of the variants which are circulating and which vaccines are available. I have to say that the administration of the COVID vaccine is quite controlled at the moment, isn't it? So it's not that as clinicians we have the ability to personalize the treatment. So we need to come up with guidelines which apply nationally, at least at a minimum, so that we can then make them available. Dominates, but certainly that's a population that needs studying because it will be a risk and reduce responses. I also like to ask, and I don't know if Oliver has thoughts around this, of post-vaccination testing, and I'm thinking around antibodies, yes, but what about T-cell immunity? Could we use ways to optimize our understanding of whether the patient has been protected, the patient at risk as defined now, has offered protection and for how long?
And that was my last question exactly for Olivier. So if you can answer that, then yes. We're at the end of the session. Great question.
Okay. Yes, Diana, Anna Maria. I think that's a very important point. There is a good correlation between antibody titers and protection. So the easiest way is to measure the levels of antibodies, and you have some ELISA assays which are very good. Well, they are not necessarily adapted to the variant, so you need to be cautious in the interpretation. And looking at the cellular immune responses is also of interest, but in a routine practice, I think it's much less easy, as you may know, because you need to stimulate the cells and to look for specific cells. So my personal opinion is that if you have a good antibody response, then you can consider that you are protected, and that should be sufficient.
So yes, we need to do those experiments. Always interesting to see how the T cells correlate with these cell responses. Big question still there. So I want to thank you both very, very, very much. And I look forward to seeing you. I think there may be other questions. I would encourage people to reach out to you directly if there are other important questions. And there were many. I'm sorry I couldn't get to all of them. So thank you again.
Thank you very much.
Diana, Jean-Pierre.
Bye, Oliver. Bye, Diana.
Anna Maria, see you. Bye-bye.
Bye.
в это поверить. Это такое фуфло, этот английский вонючий. Его даже понимать не надо.
Нет, понимать его надо, очень важные вещи интересные рассказывать.
Да, мне так надо. Его нечего понимать, там все простейшее. Ты его французский поучил.